let me introduce to you our speaker for today, Dr. Mark Pippinger. He is a consultant in behavioral and general neurology at the South Arkansas Medical Associates Group in El Dorado, Arkansas, and he's an associate clinical professor of neurology here at UAMS. And I'm not going to take any more of his time. I'm going to turn this over to him, but he has always done an outstanding job on this, and I am looking forward to hearing.
Thanks very much. I appreciate the chance to get to come and be part of this. People that know me know that I always like to talk. I lived 2 years in Ireland, and they don't let you live there if you can't talk, so you have to be able to hold your own. And I always appreciate the chance to talk about something that I love, and that's I don't love Alzheimer's disease, but I love taking care of people who have Alzheimer's disease and trying to educate about it. So my background is as a neurologist, and my fellowship was as a behavioral neurologist. And I did my medical school here, and my fellowship was at UCLA. So that's kind of that little bit of background. I've spent some time, my hometown's Jonesboro, so hopefully the St. Bernard's folks are out there, and some of the people from Northeast Arkansas. And then, of course, I'm currently also now in El Dorado, so hopefully the El Dorado folks are out there. So hello to all of the remote sites, actually. So the topic that I'm talking about today, we've entitled The Myths of Alzheimer's Disease, and it's an interesting idea to look at some of the things people think about Alzheimer's disease, its diagnosis and treatment, that maybe aren't quite so true. In approaching this, I looked at it by looking at what other people have found to be the most common myths they encounter, and then using my own experience of what other doctors tell me and what patients and their families tell me. I thought it would be useful to compile a list of, let's say, 10 of the most common misperceptions or misconceptions. And as with any kind of myths, there's often a kernel of truth behind whatever it is that people think, but it kind of illuminates a little bit about the disease. So, and there are copies of my slides available too, so we'll just barge right ahead. And I'll try to leave a little room at the end for some questions. So here we go. The first myth, I would say, that I run into very commonly is the idea that memory loss is just natural with aging. So commonly, when I see somebody who has significant memory loss, significant enough to represent dementia, which, as you know, we define as loss of memory and thinking that's sufficient to interfere with function. So when I see people with that, I commonly have the comeback that, well, you know, he's 85, and that's natural at that age. You know, that's normal, isn't it? But it's not. You know, I tell people about testing a man when I was at UCLA, a 103-year-old man who incidentally was put in a nursing home by his 48-year-old wife, which was interesting, but nevertheless, he was quite normal mentally, cognitively. He was a World War I veteran, which was interesting. So, but he was normal, 103. So memory loss isn't necessarily just a part of aging. We could say that memory does decline in some mild ways with age. So memory, especially for names of people, or in some cases, the ability to remember the word you want to use in conversation on the spot. That often declines a little bit. So there are some declines that we see with age, but it never really interferes with function. The normal memory loss or cognitive loss of aging really doesn't interfere with function. So people may be having a little hard time recognizing their high school classmates at the high school reunion, or may stumble trying to tell you the name of that projector thing there or microphone, but usually it comes back to those folks, and it doesn't cause them to not remember to pay their bills or not remember which medicines they're taking or when, so it doesn't really interfere with function. So we could clearly say that dementia itself is not inevitable with age. It's common, but it's not an inevitability of getting older. So if you live to 100, you won't necessarily be affected with dementia. The second common thing that I run into, and I run into this very commonly out in clinical practice, the idea that dementia and Alzheimer's disease are separable. They're two different things. I very commonly have providers call me up and say, I'd like you to see Mr. Jones because I don't know whether he has Alzheimer's disease or dementia. And, you know, to the behavioral neurologist, sometimes we'd say it's a little amusing. They're not really different diseases, they're different types of terms, however. Dementia isn't really a disease at all. Dementia is just a general term that we use to refer to the syndrome of declining cognitive power. Depending upon the definition, we would say that it involves memory, or arguably may involve just a change in personality, behavior, and function. But it's sufficiently severe to interfere with the ability to function. Alzheimer's disease is simply the disease that is the most common cause of dementia. So Alzheimer's disease we define pathologically by the cellular changes seen, the deposits of amyloid protein, the deposits of tau protein in the brain that we see on tissue examination. That's the pathological definition of it. So it is a disease. It frequently or inevitably will cause dementia if someone has Alzheimer's disease long enough. We are now able to diagnose Alzheimer's disease before someone actually has dementia in many cases. So we can diagnose it when people are still at a stage we would call mild cognitive impairment, which is short of full-blown dementia. Now, not everybody with mild cognitive impairment has Alzheimer's disease, but it's now possible to distinguish a subset of those people with mild cognitive impairment who are very likely to have Alzheimer's disease, and those are people we want to watch because they may progress. But so dementia, if someone has Alzheimer's disease, they will always wind up with dementia, but many people have dementia that's not related to Alzheimer's disease. The other relatively common causes of dementia that we'll run into, just to remind you, the second most common is a disease called dementia with Lewy bodies. It differs from Alzheimer's disease because with dementia with Lewy bodies, people commonly have Parkinsonism, so symptoms of Parkinson's disease, or they commonly have spontaneous visual hallucinations early in the course of dementia. With Alzheimer's disease, visual hallucinations are not common unless you give someone a drug that provokes hallucinations. So delirium in someone with Alzheimer's disease will cause hallucinations. But usually we don't see that with Alzheimer's disease until late in the disease. One must be careful if you're a provider and you're talking with family and they say that mom is hallucinating. It's important to make sure that they're not talking about delusions. Delusions are common in Alzheimer's disease. Those are false beliefs, but they're not an actual sensory experience. So the person with Alzheimer's disease may tell their family, well, there's people living in the other end of the house, and you assume that they saw someone, and that's not always the case. So I always try to distinguish, are they actually saying, I see somebody there? And if they actually see somebody or see people or animals, then that's more common with dementia with Lewy bodies. So Lewy body dementia is Parkinsonism, hallucinations. The third core feature of that is very strong fluctuations or big changes in the degree of dementia or degree of alertness. So dementia with Lewy bodies turns out, as I say, in all autopsy studies I've seen in the last few years, the second most common cause of dementia. Another relatively common cause are the frontotemporal dementias. And FTD, or frontotemporal dementia, refers to a group of degenerative disorders in which the frontal and or the temporal lobes are affected out of proportion to the rest of the brain. Frontotemporal dementia is different from Alzheimer's disease in many cases, not always. Sometimes it looks a lot like Alzheimer's disease, but it tends to be different in a couple of features. Number one, it's much more common at younger ages than Alzheimer's disease. So frontotemporal dementia, the bulk of those patients have an onset before age 65, where, as I'll talk about in a second, the bulk of Alzheimer's cases are after age 65. So frontotemporal dementia tends to affect younger people, and frontotemporal dementia often begins with behavioral changes because the frontal lobes are affected and the frontal lobes allow us to behave normally. When those begin to deteriorate, we don't behave right. So frontotemporal dementia is characterized by behavior changes early on in most cases. The other major subtype, by the way, of frontotemporal dementia are the progressive aphasias. Primary progressive aphasia refers to a steady decline in language function in the absence of any structural abnormality like a tumor or stroke. So they look like somebody who's had a stroke, who has aphasia, except they never had a stroke. And instead of having a sudden onset of the aphasia, it comes on gradually and just keeps progressing. primary progressive aphasia is one of the types of frontotemporal dementia and doesn't always develop other cognitive changes. In most cases they do, but not always. So the FTDs are in most series at least third or fourth most common cause of dementia. I'm seeing a disturbing number of them lately, and I don't know if that's a true increase in incidence or because we're a tertiary center here at UAMS, we get that selected out. Now, vascular dementia refers to dementia caused by strokes. Vascular dementia includes what's called multiple infarct or multi-infarct dementia, where multiple large strokes cause dementia, and includes also a syndrome called the single strategic infarct syndrome, in which a single stroke in a behaviorally important part of the brain causes the onset of dementia, and controversially may include a state called lacunar state, état lacunaire, where multiple lacunar strokes, the smaller strokes that happen deep in the white matter, multiple ones of those accumulate to produce cognitive impairment. It's controversial because it's been difficult to demonstrate a lot of those cases. So in most autopsy series, vascular dementia accounts for a smaller percentage. And in clinical series, suspicion of vascular dementia is often high, but at autopsy, it usually turns out those people have Alzheimer's disease in most cases. So most people we diagnose in the clinic with vascular dementia turn out to be Alzheimer's disease. But these four causes account for most of the people we'd see in clinic. And if you look at Florida Brain Bank data, where they looked at the pathological diagnosis on all the cases of dementia in their registry, the majority of the patients had Alzheimer's disease either alone or in combination with other pathologies. So Alzheimer's disease and dementia with Lewy bodies may overlap. Alzheimer's disease and vascular dementia may overlap. And if you look at the little pie chart, you can see the big red wedge is pure Alzheimer's disease. The next wedge around, 17%, are Alzheimer and Lewy body disease. And the purple wedge is Alzheimer and vascular dementia. And the little 2% is all three of those pathologies. But Alzheimer's disease is present, as you can see, in over 3/4 of the people who have dementia. So Alzheimer's disease is very common. And then pure Lewy body disease in most series is around 9 or 10% of the sample, with pure vascular dementia being only about 4 or 5% in most samples. So at any rate, those are the most common causes. They're not all Alzheimer's disease, but because Alzheimer's disease is so common as a cause of dementia, though, that's why many of us will refer to the two sort of in the same breath. Or we'll often use dementia and Alzheimer's disease almost interchangeably, because most people we see with dementia will have Alzheimer's disease, but that's probably not the best way to do it. You know, dementia really is a broader term, a syndrome, rather than a disease. Now, the third myth that I have is Alzheimer's disease only happens to old people. Now, there's a kernel of truth in this because, as I said a minute ago, the bulk of cases do happen to older people. We used to use, as the definition for Alzheimer's disease, the onset of the disease before age 65. So in Dr. Alzheimer's original description, the patient he described was someone who was 50 when she died. Her symptoms came on in her 40s. Auguste, the famous French patient that Dr. Alzheimer saw, was quite young. So the original definition of Alzheimer's disease was the onset was under age 65. But in the 1960s or so, it was recognized that the same brain pathology happened to people who had what used to be called senile dementia. So we still see that term crop up in places, senile dementia or senile dementia of the Alzheimer type. We now recognize that as Alzheimer's disease. So it's all Alzheimer's disease. Looked at in that way, the majority of cases happen to people over 65. However, onset in the 30s and 40s can occur. And in fact, about 5% of people who have dementia due to Alzheimer's disease, 5% of those are under age 65. And that means in the United States, we have nearly 250,000 people with early onset Alzheimer's disease. And the youngest patient I've seen was a woman who was diagnosed at age 27. Now, it should be pointed out that Alzheimer's disease commonly occurs in people who have Down syndrome, and it occurs at a younger age in those individuals. Down syndrome, if you'll remember, as I'll talk about in a second with genetics, Down syndrome patients have 3 copies of a chromosome that has the amyloid precursor protein on it. the gene for that on it. And so they get 3 doses of that, and that's enough to give Alzheimer's disease. In every known case that a person with Down syndrome has died at a relatively more advanced age, over age 25, we find evidence of Alzheimer's disease in the brain. Whether it causes clinical observable changes in the person or not is less constant. However, pathologically, we always see it. So those people, if you take those out as young onset, because that may be a different thing, if we just look at familial Alzheimer's disease or sporadic Alzheimer's disease of early onset, that's nearly 250,000 people in the United States alone. And as I say, the youngest is quite young, and I've seen someone aged 27 at time of diagnosis who had autopsy-confirmed Alzheimer's disease after death. So it can happen in much younger people. The fourth thing that I hear commonly is that people will come to me extremely worried because their mother has Alzheimer's disease, and maybe I diagnosed their mother with Alzheimer's disease, and so they feel now that they will certainly develop Alzheimer's disease. We talk a lot about the genetics of Alzheimer's disease and the familial risk of Alzheimer's disease, so it's quite natural. Again, there's a little kernel of truth in that Alzheimer's disease risk does seem to go or run in families. So the risk is higher in first-degree relatives. Having a parent or a sibling who has Alzheimer's disease, or in some cases a child who has Alzheimer's disease, increases the risk that an individual will develop Alzheimer's disease themselves. And yes, I have had it happen that a patient in her 80s had a daughter who was previously diagnosed with Alzheimer's disease, and the mother did not develop dementia until her mid-80s. So I have had parents of people with Alzheimer's disease develop the disease themselves later on. So, but a first-degree relative means that your personal risk of Alzheimer's disease will be increased by a factor of around 1.5 to 2 in most studies. So the risk does run a bit higher in families, but it's not 100%. There are some forms of Alzheimer's disease that are genetic, certainly, but those account for around 1% of all the cases of Alzheimer's disease. We feel that genetic factors may influence as many as 10 to 20% of cases of late onset Alzheimer's disease, older onset Alzheimer's disease. But having your personal risk increase from a lifetime risk of around 10% if you live into your 80s to a lifetime risk of around 20%. That's what we're talking about. So it's far from 100%. So having a family member with Alzheimer's disease does not mean it's inevitable in your case, but it does mean you should probably pay more attention perhaps to research about how to prevent Alzheimer's disease, and that's what I usually tell people. So are there better ways of estimating the risk that a family member will develop the disease? There are not currently. If someone is asymptomatic, there are not good ways of assessing whether or not that person will develop the disease. And you should know that these genetic forms of Alzheimer's disease, which the genetic forms include the presenilin 1 and presenilin 2 gene mutations, which affect a protein that has to do with amyloid protein processing in the brain, and the amyloid precursor protein gene. These are the 3 genes in which abnormalities have been shown to actually cause Alzheimer's disease. But again, they account for only 1% of all the cases. Almost half of the early onset Alzheimer's disease cases may be due to a genetic abnormality, but altogether that's less than 2%, so we say around 1% of cases. So not that common. The genes that influence risk are several, although the one that has the clearest influence on risk of Alzheimer's disease and the one that you hear the most about is the apolipoprotein E gene, the E4 allele. The gene has 3 different alleles, E2, E3, and E4. E2, if you're lucky enough to have that, and it's not very common, the E2 allele appears to protect against Alzheimer's disease. It lowers the risk, but the E4 is the so-called bad gene, which increases the risk of Alzheimer's disease. Having a single copy of the E4 allele increases the risk about 2-fold, perhaps 3-fold, but about 2-fold. So again, knowing that one has one copy of the E4 gene means that one knows that your risk is about what it would be if you had a family member with Alzheimer's disease. Having two copies of the E4 allele raises the risk by a factor of 20 or 30. So two copies is very high risk of Alzheimer's disease and also very rare. So very few people with Alzheimer's disease have two E4s. No, the ApoE gene testing, you can do that. It is not recommended that it ever be done clinically. We do it in research, but it is strongly recommended by every professional organization I know that deals with Alzheimer's disease. Do not obtain genetic testing on patients with Alzheimer's disease to predict whether they have Alzheimer's disease, to help in diagnosis, and certainly don't do it on the children of people with Alzheimer's disease to predict whether or not they will get Alzheimer's disease. Gene testing may be useful in early onset Alzheimer's disease in selected cases, but only after careful genetic counseling. So in familial Alzheimer's disease where a gene mutation is known, genetic testing falls under a similar category as with Huntington disease. It's controversial as to whether there's any point in doing it, and with proper genetic counseling, it may be something to do, but so children of someone who's known to have the genetic form of the disease who want to know for purposes of planning whether to have children themselves, that may be appropriate, but only after referring to genetic counseling. So we clinicians should never order those tests on our own in the clinic. So there you go. Thank you. And I've gotten into arguments with providers before who like to do the gene test, a ApoE gene test, but I always tell people don't do that. So it's a risk gene, but we don't know enough about whether it has any utility to know that. The fifth myth that I hear family members say, actually commonly, is that Alzheimer's disease can only be diagnosed at autopsy. Well, once again, there is a kernel of truth to that, because our gold standard for diagnosis is a tissue diagnosis. I said a minute ago that how we know that dementia is caused by Alzheimer's disease, how we know for sure, is the tissue. Alzheimer's disease is kind of defined that way. It's the disease with the plaques and tangles, and a certain pattern of the pathological changes is what we define as Alzheimer's disease. So in a sense, the gold standard 100% diagnosis is tissue-based. However, studies have shown that clinical diagnosis alone, using our clinical criteria, the old criteria were the NINCDS ADRDA criteria, and the new criteria published very recently are from the National Institute on Aging, Alzheimer's Association. And both these sets of criteria are felt to be very accurate. Most of the data on accuracy of clinical diagnosis come from the old criteria, and they're estimated to be anywhere from 90 to 95% accurate clinically. So clinical diagnosis alone is highly accurate. So it's not really true to say you can only diagnose the disease at autopsy. That may be the 100% gold standard diagnosis, but we can be pretty darn sure clinically in life. And just with a person who's skilled or experienced in the diagnosis using clinical criteria alone. So what are those criteria? Well, I like to run through them at some point in any talk. So when Alzheimer's disease is likely is when there's dementia with prominent memory impairment, whose onset was insidious and after age 65. Now, I said a minute ago, it's not always in older people, but we can be far more sure that it's Alzheimer's disease if the onset's after 65. If the dementia is progressive and the neurological exam is pretty much normal, other than the mental status exam. If all of those things apply, then it's pretty clear, pretty certain that one is dealing with Alzheimer's disease. Again, the likelihood is 90 to 95%. So that's just the criteria in a nutshell. And someone will always say, oh yeah, but on line 12 it says, no, I mean, this is basically the criteria. When is Alzheimer's disease not likely? So when we're faced with someone with dementia, and we're trying to say, is it Alzheimer's disease or not, if there was a sudden onset of the dementia in association with a clinical stroke, well then that makes it a little more likely to be vascular dementia. Stroke-associated dementia typically happens in people who've had a stroke. That seems to make sense. However, that subtlety is lost occasionally. So I see people every day. In fact, I saw a man yesterday who was diagnosed firmly with vascular dementia, multi-infarct dementia, and his brain MRI was completely normal, so not a single stroke. So people with vascular dementia have a stroke, and it typically the onset of the dementia is sudden in association with that. And so if there's a sudden onset and association with a stroke, it's not as likely to be Alzheimer's disease. If there are hallucinations early in the course or Parkinsonism early in the course of the dementia, it's less likely to be Alzheimer's disease. And if there was the onset of behavioral changes before the onset of memory impairment, it's more likely to be one of the frontotemporal dementias. So less likely to be Alzheimer's disease in that case, although it may be. Auguste, the patient that Dr. Alzheimer described, was said to have begun her illness with delusions. She had delusional jealousy. She felt her husband was having an affair and he wasn't, which might have been unusual in France, I don't know. But in any event, it was verifiable, he wasn't, and she thought he was. Well, that evidently was her first symptom, delusions. So occasionally we see people with behavioral change. But if you see that, it's less likely. And finally, if the dementia does not progress, after a long period of time, people with no progression of dementia, we become suspicious that it may not represent Alzheimer's disease. It becomes a little less likely. Now, this again is a distillation of criteria from the new diagnostic criteria about when not to suspect Alzheimer's disease. It's still possible, but it's less likely. So, but with the clinical criteria, when people meet those criteria for probable Alzheimer's disease, it's very, very likely that that's what we're dealing with. Another myth I hear, and this affects caregivers and families very prominently. Hopefully, all of us professionals are over this. But right, the idea that Alzheimer's disease is a psychiatric diagnosis, so it means you're crazy. So I've had people say, I don't think Dad has Alzheimer's disease. He's not crazy. Or people say, oh, I don't want you to tell me I'm crazy. I don't want to get checked for Alzheimer's disease. So, but Alzheimer's disease is not really a psychiatric problem. It's not considered to be, although initially it was. So again, there was a kernel of truth. So at first, Alzheimer's disease was placed in the realm of the psychiatrist. It was a behavioral problem, wasn't it? The mind deteriorated, and there were these funny behavioral changes. So it was thought that this was a form of insanity. In fact, one of the first homes that was dedicated to housing and taking care of people who had Alzheimer's disease was actually in Dublin, Ireland. It was very close to the St. Patrick's Cathedral. The dean of St. Patrick's at the time was Jonathan Swift, and he was more or less the chaplain at that facility. So one of the chapters in Gulliver's Travels, if you'll remember, was about the people that kept getting older and never died. And what happened to them was influenced something by his experience in the sanatorium near St. Patrick's, which housed mainly, as we know now, mainly housed people with Alzheimer's disease, although we didn't call it that back then. So, yeah, initially it was thought to be a mental disorder, but Dr. Alzheimer himself proved that it was not. It was a physical disorder of the brain, characterized by the plaques and tangles. So, and this was one of the first cases of something that we thought was a mental disorder being proven to be a physical brain disease. This is still addressed by some in psychiatry, however, and so that muddies the water a little bit. The Diagnostic and Statistical Manual of the American Psychiatric Association continues to list diagnosis codes and criteria for diagnosing dementia, although controversially, the DSM-5, the new edition that's about to be published, or it may already have actually been published, the DSM-5 proposes to eliminate the term dementia. And that's very controversial. They said there's a stigma attached to that, so we want to eliminate that. And most of us in neurology don't really use the Diagnostic and Statistical Manual for making the diagnosis. We use our other criteria as far as that goes. But so there are still diagnostic codes and criteria in the psychiatric manual, so it's understandable why people would confuse that. But I try to make it plain to families and caregivers, it's a physical disease of the brain. It's not really a mental disorder or a psychiatric disorder. Very commonly, doctors will tell me that they know that patients that have Alzheimer's disease are never aware that they have anything wrong. So they say, I don't think Mr. Jones could have Alzheimer's disease because he complains about his memory. And that's actually a myth. It's not always true. It is, again, a kernel of truth, because as many as half of people with Alzheimer's disease throughout the disease may not be aware that something's wrong. But in a study that was done at UCLA, about 60% of people with mild Alzheimer's disease were actually aware of their impairment. So it is not necessarily the case that people with Alzheimer's disease are unaware. The unawareness of the disease is something we like to call in neurology anosognosia, the fancy kind of Latin term for no knowledge of the disease. We also use that term most commonly in referring to people who've had a right hemisphere stroke and are unaware that there's anything wrong with the left side of the body, but it also can apply to people with Alzheimer's disease or other dementias. So they possess no insight into the fact that they're demented. That happens, as I say, in about half of patients in early disease, but in later stages of disease, most people will not really be fully aware of what's going on. But some do. So many family members subscribe to the idea, which I term a myth, that all patients with Alzheimer's disease will go through an angry phase at some point. So people ask me that all the time. You know, you said Dad has Alzheimer's disease, and he's been pretty easygoing and easy to get along with. We want to know, when does he hit the angry stage? But it's actually not true. Behavioral symptoms are common in Alzheimer's disease, but they're not inevitable. And we now use a fanciful term, so just so you'll be up on the terminology, behavioral symptoms refer to things like agitated behavior, anxious behavior, wandering behavior, hallucinations and delusions are behavioral symptoms of Alzheimer's disease. But we now refer to these collectively as behavioral and psychological symptoms of dementia, or BPSD, for shorthand. Behavioral symptoms are common in Alzheimer's disease, but again, they're not inevitable. But the important point is individuals differ in which symptoms they may express. So while behaviors are common, the most common behavioral symptom is apathy. So the loss of drive, or the loss of desire to do things. So the person with Alzheimer's disease is no longer interested in going fishing, no longer interested in needlework, no longer interested in, one family actually complained that their mother was no longer interested in the Beverly Hillbillies. And this distressed them because she used to set great store by watching the Beverly Hillbillies and wasn't interested anymore. But so that's actually most common. How often is angry or agitated behavior seen? In most series, up to a fifth of patients with Alzheimer's disease may express that, and many times it's due to caregiver interactions. And so many times by educating people, we can prevent folks with Alzheimer's disease from becoming angry. Although an interesting study in Great Britain devised a scale for measuring how kind of irritable people are, called the disagreeableness scale, and you could get a score on the disagreeableness scale. I note academics in the United States are reluctant to bring that in here. I don't know why. But anyway, studies have shown that the higher the disagreeableness factor before onset of dementia, the higher the likelihood of agitated behavior during dementia. So people who are ill-tempered and hard to get along with before they get dementia are more likely to be ill-tempered when they become demented. There are a lot of exceptions, but that's just the general common theme is people tend to express similar behavior once they're demented to what they did beforehand. Again, unless we provoke them. But not everybody goes through an angry phase. A ninth myth is something that, again, hopefully most professionals are aware is a myth, but something I hear repeatedly. And just the other day, someone sent me a video wherein Dr. Oz proclaimed that we now have the cause of Alzheimer's disease identified, and it was a food additive. So with apologies to Dr. Oz, research has so far not linked any particular chemicals in food or food additives. Aspartame comes up a lot lately, and I don't know what the people who made aspartame did to irritate folks generally, but for some reason aspartame is blamed for a lot. I think it may be because I believe if aspartame is heated up to a very high temperature, like boiling or close to boiling, it can transform into formaldehyde. And so the suggestion was, well, that's why if you're cooking with aspartame, they tell you to add it after you've boiled the food or whatever, not before. But I don't even think then it's such a big toxic risk. So nevertheless, maybe that's why it comes in for that. But there's no credible evidence linking those. And the other things, there's no credible evidence that aluminum ingestion influences the risk of Alzheimer's disease. So you can drink from aluminum cans and you can use your aluminum cookware well, I won't say with impunity, but however, there's no risk that you're going to get Alzheimer's disease, no increased risk of Alzheimer's disease. It's estimated, by the way, if you live on a gravel road, you ingest more aluminum from the dust coming from the gravel road than you'll ever get out of a drink can. And so we don't see Alzheimer's disease more commonly in people that live in areas with high aluminum. So we don't believe that that causes it. And there's no evidence that preservatives in food cause Alzheimer's disease. So with all due apologies, we have no credible evidence yet. And finally, the last myth, which is the saddest myth, is that there are treatments that can stop or reverse Alzheimer's disease. There was another thing, someone sent me a video from, I don't think it was Dr. Oz this time. I'll quit picking on poor Dr. Oz. But another medical show on television announced that we could now stop Alzheimer's disease in its tracks by the use of coconut oil. So we'll talk about, there's several things that, treatments that people say can stop or reverse it, but we have nothing that has shown the ability in studies to stop or seriously reverse the disease. We do have current treatments, and they provide a small benefit, but all they do is a small delay in decline. There's no drug that's known to slow the progression of the disease itself. This is kind of a holy grail, of course, in research in Alzheimer's disease. If we could find something that would even just slow down the degenerative process, that would be wonderful. But we don't have anything that has shown that ability yet. Drugs that are claimed to affect the progression of the disease include one clinically available drug, memantine, sold under the brand name Namenda, is often marketed as a neuroprotective agent which can slow neurodegeneration and reduce the death of neurons and therefore slow down progression of Alzheimer's disease. It flatly does not. So that's that. It just doesn't. So studies have shown no effect on disease progression. And it's a type of drug called an NMDA antagonist. Stronger NMDA antagonists have been studied, and they show no effect in slowing down progression of Alzheimer's disease itself. B vitamins are much touted as a supplement that can slow down disease, and I'm told that I have heard personally from representatives from companies that sell proprietary mixtures of B vitamins, so available only under their brand name, who claim that their B vitamin mixture slows down disease progression. We have clear evidence B vitamins do not. They do not affect the progression of Alzheimer's disease and don't appear to affect the risk of getting it. Nutraceuticals like ginkgo and vinpocetine have been studied in prospective randomized trials and shown to have no effect at all, either on progression of Alzheimer's disease or on reducing risk of developing Alzheimer's disease. So unfortunately, there's no nutraceuticals that have been shown to be effective. Coconut oil comes under the category of what you might call a nutraceutical. The lady who first talked about this is a pediatric intensivist whose husband developed early onset Alzheimer's disease, and it's not a crackpot idea. It's actually a reasonable idea that coconut oil may provide a type of fatty acid which can be converted into ketone bodies that can be used by the brain as an alternate energy source besides glucose. Some research suggests that in Alzheimer's disease there is increased insulin resistance in the brain, which might interfere with the brain utilizing glucose as an energy source. So the idea of coconut oil is to provide an alternate energy source. However, if you think about that for a second, that would not even, to my thinking, hypothetically affect disease progression. However, it might affect disease symptoms. So we have to say that coconut oil has not been studied, is not felt to be harmful in most instances to somebody who has Alzheimer's disease, but we don't really have evidence that it works. The drugs that do have effect are the current drugs that are currently available. They're shown to have very small effects on clinical symptoms mainly. And those drugs include the cholinesterase inhibitors, and these are the ones that we talk about the most: donepezil, rivastigmine, galantamine. The brand names are Aricept, Exelon, and Razidine. You might be interested to know that pharmaceutical companies try to see to it that the generic name of a drug that is selected is difficult to pronounce, so that we will only use the brand name when we're talking about it. So to this day, everyone comes in and says, Dad's on Aricept, and actually Dad's on donepezil, the generic. And so in the case of cholinesterase inhibitors, there's no credible evidence that brand names work more effectively than generics, and so we use the generic compounds. Interestingly, although generic forms of the pill, of the capsule or tablet, are available for all three of the cholinesterase inhibitors, the price is markedly different nowadays. So just as a clinical pearl, if you're treating people, generic donepezil in small local pharmacies tends to run around $10 a month, whereas generic rivastigmine and generic galantamine are nearly $100 a month for the generic. Exelon also has a patch, a skin patch. It has not shown any advantage in terms of efficacy over the other drugs. You could almost put that as another clinical myth, because I hear it so often that the transdermal patch with rivastigmine, which is the Exelon branded patch, is more effective than other drugs. It's actually not. It is now marketed with a dose form that is equivalent in efficacy to the pills. It used to be marketed only in a dose form that was not as effective as the pills. Now it's available in a higher dose. Nevertheless, it's interesting that the generic of donepezil is the cheapest by far. And that only goes for local pharmacies, I've discovered. Some of the large chain pharmacies still charge around $200 a month for generic donepezil. So if you're taking care of patients and they complain about the cost of their drug, I always advise them to check around with pharmacies, because nobody realizes they can do that. Just call the pharmacy and see how much they charge for the drug. And when you do that, you'll find an interesting surprise with the cost of some generics. So you think a generic is going to be pretty cheap anywhere. That's not always the case. But for these drugs, the effect of these drugs is all very similar. If you can get to the full dose of the drug, the effect we see is equal to delaying the decline from the disease by about a year or so. Now, that doesn't mean they only work for a year. They delay the decline by the equivalent of about a year's worth of progression. So even after a year, people who are treated with the drug still do better than people not treated or people on placebo. However, everyone is usually declining after that point. So they still provide a benefit. It's very small. And once people are taken off the drug, generally, if in a placebo-controlled trial, people in the active treatment group are doing better than the placebo group, and when they're taken off the active drug, they go right down to the same level with the placebo group. So there's no effect, as far as we know, on the disease progression. So it only affects the symptoms, and it delays the progression of symptoms a little bit. But we still think that they're worthwhile, because if you can get another year of better function, then that's valuable. That's valuable. Memantine, or Namenda, is a more controversial drug, because as more studies are done, more negative studies are reported. There are not many. There's not a robust data set for clinical efficacy of memantine. The only situation in which memantine has been shown to provide any benefit is in moderate to severe Alzheimer's disease. And then the benefit seen, the additional benefit seen, is not likely to be clinically meaningful. It is wildly different from what representatives from the marketing company tell you, in which they tell you that it will, as I say, cause your hair to grow back its original color and your teeth grow back. And so wild claims of efficacy are made. However, controlled trials, controlled studies so far show that this drug is minimally effective and only in more advanced Alzheimer's disease. Recently, a study was published in frontotemporal dementia with memantine, and it was completely negative. So the drug had no effect in frontotemporal dementia. Unfortunately, none of the drugs have an effect in frontotemporal dementia. So really, these drugs provide some small clinical benefit, but just in Alzheimer's disease. And we think in dementia with Lewy bodies, there's probably a benefit, but we don't have controlled studies yet to show that, only case series. Yes, the question was asked on the cholinesterase inhibitors and memantine, does it matter where in the stage of the disease the patient's at when the drug is started, in reference to how much benefit is seen? Interestingly, in studies where the patients are more advanced when the drug is started, a bigger effect size is typically seen. However, it's estimated that although in more mildly demented people, you don't see as much of an improvement in the short run, that probably translates into more benefit when they do reach more advanced stages. So it's felt that it's better to treat earlier in the disease. It has been difficult to prove that, but trying to extrapolate results of studies where patients are started earlier in the disease compared to studies where patients are started later in the disease suggests that although the later stage starters get a bigger immediate bump up in scores, they don't go up to the level predicted for people who are started earlier. So you see a more dramatic change later in the disease, but it's probably still better to start people on treatment earlier in the disease. Are there other questions? Yes. Yes, it's very common. The question was about behavior, and there was an observation of a friend who had a spouse, I guess, who had developed Alzheimer's disease or was likely developing Alzheimer's disease and had begun to resurrect old arguments, we'll put it that way. So had begun arguing with his wife about things that they had gotten over in the intervening years. And the question was, is that common? Well, it can often be seen. It's like erasing the last few years of progress in the relationship and going back to the old arguments. We'll often see people regress back to some earlier stage. So that can be seen in that. It's also a very common delusion is the house is not a home delusion, where people say, I want to go home, despite the fact they're at their home. That's because they've forgotten that they've lived here 15 years. They only remember the home from 30 years ago. And similarly, old arguments or fights or old sore spots that were prevalent 30 years ago may come back after a period when they become demented, because it sort of erases things and goes back. And so, yeah, that can be seen. Not always. We also see it happen that the memory loss can provide a benefit in people with post-traumatic stress disorder, in which PTSD patients don't really want to remember any of that happened that triggered their disease. So once they become demented, they actually gain from the loss of memory in some cases. So occasionally our drugs that we want to improve may worsen some other state by backing them up or bringing them back up. Yes?
Are there any questions from any of the remote sites?
This is West Memphis.
Yes.
And my question is, can you speak some more as to the protective function of ibuprofen?
Sure. Ibuprofen and other non-steroidal anti-inflammatory drugs had been suggested to possibly protect against Alzheimer's disease based on research showing that inflammatory markers are increased in Alzheimer's disease. And that suggestion was then that Alzheimer's disease might be an inflammatory disease. So you look at drugs that prevent inflammation, and drugs such as the anti-arthritis drugs, the non-steroidal anti-inflammatory drugs, are given widely for a lot of different conditions. And so people went out pretty quickly and tried to study patients who had taken a lot of anti-inflammatories. Initially, it was found that the risk of developing Alzheimer's disease was lower in people who had taken a lot of non-steroidal anti-inflammatories. In looking at different non-steroidal anti-inflammatories, ibuprofen seemed to have more of a risk-lowering effect than other non-steroidal anti-inflammatories. And theoretically, for reasons that I'm not able to address, ibuprofen is felt to be the optimum anti-inflammatory to affect Alzheimer's disease, to the point that when I was at UCLA, the researchers in the bench lab were all taking ibuprofen daily, whether they had pain or not, because they thought it would prevent the disease. Since then, research has failed to show any benefit in protective trials, so it looks like non-steroidals do not actually protect against Alzheimer's disease in clinical trials to date. Although aggravatingly, we have little data on ibuprofen specifically. We do have at least one study that showed no effect from it. So it's currently not thought that that's a robust enough effect to have people take the drug routinely. However, if I get a headache, I take ibuprofen. So. But I don't take it daily like the fellows did out at UCLA. So if I get a pain, I use that, but I mean, why not? So, but there's no credible evidence that it's enough that you could prescribe that for people. The question there was about sleep disorders and whether sleep disorders are associated with certain dementias, whether that's a reliable indicator or just an epiphenomenon, something that just happens. We have noted that REM behavior disorder in particular, so acting out one's dreams in one's sleep, is REM behavior disorder. So that's the beaten wife syndrome that we sometimes see, where the spouse has been beaten up by her husband. He wasn't beating her up, he was beating up the guys that were after him in his dream, and she just got in the way. So REM behavior disorder is clearly associated with Lewy body pathology, and in many cases of REM behavior disorder, they go on to develop clinical signs of either Parkinson's disease or dementia with Lewy bodies. The association as a percentage of the people with the disease is highest in dementia with Lewy bodies, and next highest in people with Parkinson's disease without dementia. So it clearly seems to segregate with Lewy body disorders. It's a little more common in Alzheimer's disease than it is in people who do not have dementia. However, there are people with REM behavior disorder who don't ever develop any dementia, and so it's a little difficult, although clearly people who have Lewy body dementia, as people with Parkinson's disease, should be questioned about the presence of sleep disturbance and odd behaviors in their sleep at night, because in some cases those cause quite a lot of trouble and can be easily managed with low-dose clonazepam, for example, for REM behavior disorder. But yes, we believe it's clearly related, but the predictive value of having someone with REM behavior disorder currently is a bit limited, we think. But yeah, I think it's clearly related.